Rural healthcare in America is in crisis. Hospitals are closing at alarming rates. Physician recruitment is nearly impossible in many areas. Specialists are scarce or non-existent. Travel distances to the nearest medical care can be measured in hours. For rural residents, AI health assistance is emerging not as a convenience, but as an informational lifeline. When the nearest doctor is 50 miles away, booked months out, and might not have expertise in your specific condition, being able to ask AI basic health questions feels necessary rather than optional. The scope of rural healthcare gaps is staggering. Hundreds of rural hospitals have closed in recent years, and more are on the brink of financial collapse. Many rural counties have no obstetrician, no mental health providers, no specialists of any kind. Even when doctors are present, they're often overwhelmed with patient loads that make appointment access difficult. Emergency care might require 30-minute or hour-long drives. For chronic condition management, specialty care, or any complex medical needs, rural residents often face impossible choices between massive travel burdens and going without care. AI becomes an information source when no other source is accessible. A rural resident with a new diagnosis can use AI to learn about their condition, understand treatment options, and prepare questions for their rare appointments with distant specialists. Someone managing a chronic condition can get basic guidance about symptom changes without making a half-day trip to a doctor. Parents with sick children can get information about whether symptoms warrant the long drive to emergency care. This is genuinely valuable when alternatives are severely limited. However, we must confront how infrastructure shapes access. Broadband internet in rural areas is often slow, unreliable, or non-existent. Many rural communities lack the high-speed connectivity that AI tools assume. Device ownership and quality also vary. Not everyone has smartphones, and those who do may have older devices with limited capabilities. Data plans may be expensive or limited, making extensive AI interaction financially prohibitive. This means AI tools, which should theoretically democratize access, instead may widen rural-urban divides. Rural residents who most need alternative healthcare access may be least able to effectively use AI tools. Cultural trust is another complex factor. Rural communities often have different relationships with technology and medicine than urban areas. There may be skepticism about AI, preference for in-person care, or limited health literacy that makes AI interaction difficult. Simply deploying technology without considering cultural context and providing education about how to use it effectively results in low adoption and potential misuse. Older rural residents, who often have the greatest healthcare needs, may be least comfortable with digital health tools. Proposed hybrid models show promise, but require investment. Imagine rural clinics staffed with nurse practitioners or physician assistants who can perform physical examinations and basic diagnostics, supported by AI for medical knowledge and decision support, with telemedicine connections to distant specialists for consultation. This model extends the capacity of limited rural healthcare personnel while maintaining human clinical judgment and physical examination capabilities. But implementing this requires funding to keep rural clinics open, to train healthcare workers, to install necessary technology infrastructure, to pay for reliable internet connectivity. The danger is that AI availability becomes an excuse for continued underinvestment in rural healthcare. If policymakers can point to AI tools and claim rural residents have healthcare access, it relieves pressure to address the fundamental problems of hospital closures, physician shortages, and infrastructure gaps. This would be catastrophic. AI should be part of a comprehensive strategy to improve rural health access, not a substitute for actual investment in rural healthcare systems. The solution requires both technology and traditional resources: doctors, nurses, clinics, hospitals, and the funding to sustain them.